Welcome to our webinar. We will begin promptly. Make sure your speakers are turned on. You will be muted during this webinar. Please use our chat to ask questions to our presenter. As a friendly reminder, this webinar will be available on our YouTube channel. You can download the PDF of today's presentation. Once again, welcome. We're glad you could join us. Welcome to our webinar. We will begin promptly. Make sure your speakers are turned on. You will be muted during this webinar. Please use our chat to ask questions to our presenter. As a friendly reminder, this webinar will be available on our YouTube channel. You can download the PDF of today's presentation. Once again, welcome. We're glad you could join us. The National Hispanic and Latino Mental Health Technology Transfer Center was established to develop and maintain a collaborative network to support research development and dissemination, training and technical assistance, and workforce development for Hispanic Latino populations and communities receiving mental health services throughout the U.S. mainland and the Caribbean. We offer free technical assistance. If you want more information, please contact us. The National Hispanic and Latino MHTTC is under the direction of the Institute for Research, Education and Services in Addiction, IRESA, and housed at the Universidad Central del Caribe School of Medicine in Puerto Rico, and supported by the Substance Abuse and Mental Health Services Administration, SAMHSA, of the U.S. Department of Health and Human Services. As mentioned, the Mental Health TTC network is funded by SAMHSA. SAMHSA strives to reduce the impact of substance use and mental health disorders on U.S. communities throughout its programs and services and demonstrates that behavioral health is essential to health. Prevention works, treatment is effective, and people recover from mental and substance use disorders. You can learn more about SAMHSA by visiting www.samhsa.gov. And now our moderator.
Hi everybody, welcome to our webinar. We're glad you could join us. So today we have Dr. Ning as our presenter, and I'm gonna introduce him. Dr. Ning was born in Mexicali, Mexico. He is a medical graduate from the University of Nuevo León in Mexico, who completed residency both at Texas Tech University and the University of California in San Diego in the United States. He is certified by the American Board of Psychiatry and Neurology, the American Board of Psychosomatic Medicine, and the Consejo Mexicano de Psiquiatría. His activities include the direction of the Sun Valley Behavioral and Research Centers in Imperial, California, and Centro Geriátrico Nuevo Atardecer in Mexicali, Mexico. Dr. Ning is a clinical assistant professor at UCSD, president of the American Society of Hispanic Psychiatry, and president-elect of the Asociación Psiquiátrica Mexicana. He is also chair of the Council of International Psychiatry of the American Psychiatric Association and advisor for the National Hispanic and Latino Mental Health Technology Transfer Center Network. He has 76 publications, including 34 original articles, 29 abstracts, 6 book chapters, 4 handbooks, and 3 books, and has conducted 61 clinical trials as principal investigator. So now that we know a little bit about our presenter, we're gonna get to know our audience. So we're gonna go ahead with our poll questioning. Okay. So our first question is, do you currently serve Hispanic and Latino populations with serious mental emotional disturbance? And 72% of our audience says yes, and 28% say no. Our next question. Are you planning to serve Hispanic and Latino populations in the next 6 months? And 85 of our participants say yes, 2% no, and 13% don't know. What is your current professional role? Okay, and among our audience, we have 21% social worker, case manager, 35% counselor, therapist, psychologist, or nurse, 13% faculty, researcher, student, 12% government, and 21% other. What type of setting do you currently work in? And we have 12% university higher education, 26% treatment, 29% government, and 31% other. So we'll now proceed to our pre-post questioning, and the first question is, which of the following are considered social determinants of health? Okay, and we have 2% working environment, 98% all of the above. Which of the following is considered a cognitive disorder? Okay, we have 31% major depressive disorder, 0% obstructive sleep apnea, 51% major neurocognitive disorders, and 17% none of the above. And our last question. The following are surface structure cultural adaptations in psychotherapy except. Okay, and we have 34% say language, 44% say clothing, 13% religion, and 9% music. So that's it for our questions today. Thank you for participating. And now we're going to proceed with our presentation.
Okay, am I on now?
Yes, you're on. We can see your screen and we can see you.
Well, hi everybody. Thank you for attending. Thank you for the invitation. I'm very pleased to join. The first thing I realized as you were presenting me is that I need to send you an updated photo for next time. Okay, well, so thank you for dedicating part of your time or most of your time in treating Latino and Hispanic patients. I will share with you some of the experience I have accumulated in the last couple of decades working in this area of the United States. I'm located in California and I'm right at the border. So this community that I work at with a very cool team of most of us either Latinos or bilingual staff treating patients who are in a community that's about 80% Latinos with different degrees of acculturation. And my presentation is going to have the following items. And at the end, I'll be presenting a short video of an actual patient that hopefully illustrates lively what I'm going to try to explain to you in my slides. Also, I'm going to try to leave some time for questions at the end of my presentation. So the items we presented today are aging population diversity, social determinants of health, health literacy. Then we're going to talk about the differences between cognitive complaints and cognitive deficits. We're going to touch on health disparities, how they manifest in these populations. And towards the end of the presentation, before the video of the patient, some thoughts of what you can do back home, especially those that are already seeing Latino patients or plan to see Latino patients in the next 6 months. So it's well known that aging population diversity is growing in the U.S. Last decade or so, we kept saying that the Latino group of the U.S. population was mostly a younger population, but that's changing. Aging is a fact of life and is frequently accompanied by declining health. And there is some sense of acceptance that because we age, it's okay to be ill or frail or achy, especially among Latinos. And the message I'm trying to share with you today is that that's not necessarily true. And there are some changes. There are manifestations of disease that they can be treatable. And by doing that, you can improve the quality of life of your patients. And we just need to pay attention and detect this timely and not just accepted as a fact of life. The idea then is that at the end of this presentation, you give some thoughts of how the healthcare system must use health-promoting messages that resonate with older Latino needs and their preferences. What I'm going to present to you now is from a survey done at a day program where they interviewed Latino and Asian older patients, and in a qualitative mode, these were the 5 kind of messages that the patients who felt really good about themselves communicated that they liked to hear, that they believed in, and that helped them move forward as they were aging. And so the first one was the thought of both physical and mental health. The other one was to be optimistic and acceptant about aging. The other one was to remain socially connected. And the last two are very interesting because that, in my mind, offers a change in what we believe Latinos would go by. And these two have to do with independence and self-worth. We have the idea that the older generation of Latinos were expecting that their children will take care of them, their adult children, and it's not so common now. It seems that Latino elderly, very much like other members of society in the United States, strive and look forward to being independent and to being in charge of their own health. So, what is social determinants of health? Well, it is increasingly accepted that health depends on the quality of the environments where people are born, grow up, live, work, and in this particular case, age. And this may sound as nothing new to some of you, but you will agree that a decade ago or so, we focused so much on genetics, biochemistry, physiology of the body, and it seemed as if we forgot or paid less attention to the social determinants. And, you know, as the pendulum is coming back to a happy medium, researchers are paying attention again to the social determinants of health. Well, this is only one way of looking at this, how the different variables play so that health of the individual can be maintained, can deteriorate, or can improve. And this one is divided on how from the policy domains to the domains of the institutions to that of the individuals, translate into the last column, the one to your right, which is the health indicator. In particular, with the Latino elderly, I would highlight that immigration enforcement is an issue. We are here right at the border, and a lot of our Latino elderly have their grandchildren who, for one reason or another, do not live in the United States. They live on the Mexican side, for example. And this becomes an issue because once their health deteriorates and they're no longer able to be moving or transporting themselves to the Mexican side to visit their family, becomes a source of distress. And here I'm telling you, in a border where you can cross by foot or by car any time of the day, any time of the week, this can be even a greater issue on Latino elderly who do not live as close to the border or whose relatives are not in Mexico, but they are in Central America or South America or the Caribbean. The other thing is education. Unfortunately, as a group, Latinos have lower levels of education compared to other ethnic groups in the U.S. and within the Latino group. those with Mexican ancestry unfortunately have lower levels of education, as I'm going to be mentioning later on, that has an impact on what we call health literacy. And finally, the access to health services. A lot of our Latino elderly are represented highly in the working class, and many times with lower salaries, and end up depending on government-sponsored health insurance, which delays their access to health services. And I'll be talking more about that later on. Okay, so what is health literacy? Well, health literacy is a concept that has to do with a patient's ability to access health care, obtain medications, and this is very important, comprehend instructions. In the case of discharge instructions, for example, from a hospitalization, can make a big difference between the way they're going to recover, the way they're going to function as they move forward in the care of their health. So functional health literacy can be diminished by, as I mentioned before, lack of education in the part of the individual, but also cultural factors in the part of the health system. And as we all know, the inability to comprehend the language. So Hispanic Americans aged 65 and older are a vulnerable population at risk for diminished health literacy. Improvement can lead to better control of chronic disease. And this is one example. Here we go. So what are the options to improve literacy of all Latinos? Well, one of the things that those of you who are clinicians or case managers you're probably already doing based on your common sense is to identify the learner. So in the older Latino patient, especially if he's starting to show issues with his or her cognition, then it's very important to identify a family member or a caregiver that sometimes may be the same person with whom confirm, secure the messages that need to be passed on to keep up with the instructions and follow-up and medication and further visits. If necessary, in your health system, you may have to redesign the patient education process. And this be very helpful. It would be ideal that all health systems do, and it is to actually build a database with evidence based on literacy assessments. And here I am listing some of the assessments that have been used in published articles regarding health literacy. As you see, right after the name of each one, I put the time that it usually takes to apply one of these instruments. No one instrument is better than the other. There's one that is longer, like the short assessment of health literacy for Spanish-speaking adults, that can take up to 40 minutes and may not be feasible in some health systems. But there's one, the NVS, the News Vital Sign, that can be as quick as 3 minutes and can give you a lead as to where you are with the patient who's in front of you and what your health system can do to improve the health literacy of your patient. So the other factor is the utilization of community health workers and caregivers to assess the patient. So we know that some health systems are already overwhelmed and understaffed. So you can mobilize people from the community where you can train a few that will train themselves more people and so on and so forth, so you can multiply your efforts. And the goals or the recommended targets would be at least these three: understanding of the disease, proper medication use, and self-care management. Okay, so what are we talking about when we say cognitive complaints versus cognitive deficits? Okay, So basically, a complaint is when the patient himself or herself is stating that she is having trouble focusing, she has become increasingly forgetful, or that she's getting lost when she's doing her usual drive or traveling around the city using public transportation or driving. One of the typical examples is going grocery shopping to Walmart, and then when you are ready, going back to your car, this humongous parking lot is there, and you have trouble finding your car. So that's the usual manifestation of cognitive complaint. On the other hand, the cognitive deficits is when you can actually measure on neuropsychological testing that the individual is exhibiting deficits that go beyond what is considered normal for his age. That's on the one hand. And the other one is when the function is definitely becoming impaired due to the cognitive deficits. So it's not the same that the patient is complaining about how much trouble he had finding the car in the Walmart parking lot, but anyway, the person found his car and was able to drive home, compared to the one who, after 2 or 3 hours, has to call for help because could not find the car. Or the person whose car was stolen because he left it open with the keys and the ignition and forgot about it. Now, what happens here? Well, you can have non-psychiatric conditions or non-psychiatric illnesses that can manifest with cognitive complaints. Then we have major depressive disorder, which is especially common in this age group. And then we have what used to be called minimum cognitive impairment, that now we call minor neurocognitive disorder, and then the major neurocognitive disorder. So I'll give you examples of each one of those entities, trying to illustrate the differences in this condition. So on the first one, medical illnesses like diabetes mellitus, stroke, obstructive sleep apnea, or heart disease can be associated with difficulty concentrating, getting slower at figuring numbers, adding up how much you're supposed to pay at the grocery store, or how many dollars you want to put on gas in your car. In the case of stroke, is very evident. Depending where the stroke was at, well, obviously you're going to end up with cognitive, not only complaints, but deficits. Obstructive sleep apnea, I wanted to bring it up because sometimes it is underestimated. This illness is where the typical patient with this disease is the one that snores a lot at night. It's usually a male patient, heavyweight, who's overweight and that seems to be running out of air at night. This illness actually carries a lot of morbidity. Patients can actually have a heart attack during their sleep, and it's actually very easily treatable. These people don't sleep well, and the next day they're usually tired, they have headaches, they're very forgetful, they can misplace things, lose money, lose their valuables, only because they're so tired all the time. In heart disease, especially after a heart attack, there's a period of at least 6 months where patients do not concentrate or remember things as well as prior to the heart attack. Next condition, major depressive disorder, or clinical depression, if you want to call it, or major depression. It's very common in older adults, especially the ones where these social determinants play a role in their lives. And well, the first one is fragile health. We know, we said that it was a fact of life that health may deteriorate, but some people don't take it well and they get depressed. Also, we have people that are not very good planners, or life was not that easy for them, and ended up with a very low income during the retirement age, lost independence, or death of loved ones. And here I want to underscore a special factor, because sometimes we take it as normal that the patient is depressed because all these friends and family members are dying around him, and the older he gets, the more people he loses. Well, grief over the loss of loved ones is normal, but it's not the same as depression. Those that are listening to me who are therapists or mental health workers will know exactly what I'm talking about. In fact, when a grief process becomes complicated, that's how we call it, complicated grief, and many times it's complicated by a case of major depression. One last note on major depressive disorder is that those people that have recurrent depression and have experienced depression since their 20s, their 30s, their 40s are at a higher risk of converting or transforming into what we call major neurocognitive disorder, and I'll be talking more about that now. So, what is the difference between a minor and a major neurocognitive disorder? Okay. In both cases, you have errors in neuropsychological or cognitive testing. The main difference between the minor and the major disorder is that the minor, the individual can still function well. But if he is put through some testing, the clinician will find errors in the testing. And the difference is with the major neurocognitive disorder that the patient finds his level of functioning also affected by the disorder. And the big difference between the two is that once someone meets the diagnostic criteria for major neurocognitive disorder, then he has entered a condition which is non-reversible, and it means that the central nervous system will be degenerating. Treatment works better when started early, and the presence of major neurocognitive disorder, or what used to be called dementia, usually worsens the prognosis of other health conditions. May that be depression, may that be psychosis, may that be heart disease, diabetes, or hypertension. So as we move forward, just a few examples. I'm talking about diabetes here. For example, this was done in California, and they followed diabetic Hispanics from 1984 to 2014, and elderly Hispanics compared to non-Hispanics showed higher levels of kidney problems, amputations, losing part of their limbs. They proved that the referrals to surgery were delayed, and once they went to the hospital, they would stay longer than the non-Hispanic counterpart. Among the barriers identified in this study were cultural beliefs, folklore medicine, insulin treatment perception. I'm just going to pause there for a moment because it is, in my experience, very common that patients are afraid of getting on insulin. And it's funny because it's really the other way around. When you end up, if you're a diabetic type 2 and need to move to insulin, it's because your diabetes is not going well, very likely because you didn't take care of it properly. And somehow the perception of many of my patients has been then that once insulin starts, things go bad. And it is the other way around, because things are going bad is that insulin has to be started. And moving forward on that, the patient-to-provider interaction has been an issue. The socioeconomic status, again, coming up in this study, lack of education, and in this case also lack of social support. Another study showed almost 1,800 diabetic Hispanics, 45 to 76 years old. They proved that those that scored worse on this kind of cognitive testing, maybe someone in the audience is familiar with it, the digit symbol substitution test, which is a measures how fast you can solve problems or you can process things. Well, those with the lower scores, even if they don't have dementia, even if they don't have depression, maybe they have a minor neurocognitive disorder, they have a poorly controlled diabetes. So this is how one thing relates to the other. Things of how the cognition is working may manifest on how diabetes can be controlled or not. A few other comments here on cardiovascular disease. These authors did a study where they compared the risk factors of having a heart attack with the level of acculturation. And they found that the risk factors were not as bad if you were more acculturated, meaning if you understood mainstream messages in health, these people were able to control their blood pressure better. They had less history of cardiovascular disease. They had lower levels of the bad cholesterol with higher levels of the good cholesterol. And finally, a lower Framingham risk score. And that's basically a score that the cardiologists use to see what your chances are to have a heart attack. In the case of sleep apnea, which I already described it a moment ago, compared to the general population of 17%, Hispanic males double that risk. And again, I'm describing the gentleman that snores, who is overweight, who has probably high cholesterol, and he is at a high risk of stroke, heart attacks, and cognitive death. And mental health services is not the exception. This is a study from Danny Jimenez, my friend. He's in University of Florida. They studied 5 years worth of use of mental health services. And they looked at 5 levels of care or characteristics of access to care. And they measured the prescription drug fills, the number of outpatient visits, or both. And they called that episodes of care. And they found that Latinos were less likely to initiate treatment. So there was something that has to be probably with stigma or difficulty accessing care. But once they started care, there were no difference on how adequate was the care, the duration, the number of visits, or how much was spent, comparing Latinos to non-Latinos. However, if the patients were 80 years or older, that was a negative predictor to be able to secure proper care. Let me go to some details on that study. And I pardon for this image, I took it directly from the article, but you may have trouble seeing these numbers here. Let me see if I can explain it properly. So if you see here, oops. So this is for the white population, and then only outpatient care without a prescription of medication. It was 12% for elderly white, whereas the disparity between Latino and white was 14%, meaning that Latinos were 14% less likely to access care. Now, once they did access care, the chances to get a prescription was 28.9% for Latinos compared to white elderly patients. But when it came to outpatient care, meaning psychotherapy sessions plus medication, they were again behind. So here shows evidently, or the evidence that having or the lack of having Spanish-speaking therapists drives these patients to be more likely to receive medication than to receive psychotherapy. Okay, so what's the story with psychotherapy for major depressive disorder in these populations? Well, historically, depressed U.S. Latinos have experienced disparities. Their lack of English proficiency, treatment attrition, stigma related to fear, substandard psychotherapy services, and services that do not meet criteria for empirically supported services. This last one is very important because in the need to have more professionals do the care, sometimes clinic systems and health systems recruit people who are not as trained, but at least they're culturally more competent to address the patient's needs. And it was proven in a meta-analysis of treatment outcomes that if you adapt the treatments culturally, the outcomes are better. And from the academic point of view, there are at least two types of cultural adaptations. One of them is the surface structure adaptations, and the other ones are the deep structure adaptations. So what this is trying to convey is that you can change the environment of the clinic, playing Latino music, have people dress more in a more friendly way, even have your staff trained in Spanish. And all of that helps, but that is a surface structure adaptation. The deep structure adaptations and the ones that are more valuable to be culturally competent have to do with understanding the values, the religion, the historical references, and even the immigration issues of these Latino elderly. So, keeping all that in mind, the therapies that have shown the best results with these populations are cognitive behavioral therapy, but of course with the cultural adaptations, and in second place were interpersonal therapy and problem-solving therapy. Okay, and to finish, I'm going to talk about Alzheimer's disease, which is one of the forms of major neurocognitive disorder. That is a disorder. It's a cognitive deficit disease with or without cognitive complaints. In the more advanced stages, some of these patients will deny any complaints of cognitive issues, but it becomes very evident they're not functioning well because of the cognitive deficit. So here, the challenge is detecting as early as possible because the available treatments work early on. As the disease moves into the later stages, we really don't have much treatment to offer. So the cognitive testing is the main one measure to detect, also to monitor, and in many cases to distinguish Alzheimer's disease from other neurodegenerative diseases like dementia secondary to Parkinson, to Lewy body disease, stroke, or secondary to alcohol. Language, again, the barrier. Measurements created in one language do not necessarily translate well into other languages. So my recommendation there is that don't just translate measurements that you have in your office, but look for the reference of things that have already been translated and tested in the Hispanic population. And again, the workforce, neuropsychologists, there are very few trained to work with minority groups. We need more people dedicated to this. And one of the most commonly used bedside tests, in fact, this is the one we use in our clinic. My staff is trained in doing that, is the mini mental status examination, came from the University of Boston by Dr. Folstein. And just a warning, if this is the one you know how to use and this is the only one you use, fine, on using it. But keep in mind that people with limited education may score lower without necessarily having such bad deficits. Okay, more about Alzheimer's. There's such a thing as the cognitive reserve, and that's what we call cognitive reserve a capital, like a baseline capital that we all have regarding our brain health and cognition. And the more you went to school, the more intellectually challenged you were during your early years in life, the less diseases you had, the less street drugs you use, well, you're going to maintain a good capital. If not, if you drank a lot of alcohol during your youth or had a brain injury or have other kinds of diseases, well, your reserve goes down. So we want to promote messages where we want to tell our population to maintain that capital over time, because that improves and increases the resistance to illnesses like Alzheimer's. About neuroimaging biomarkers, currently we go by the standards, but I have to mention that we don't have as much information on Latinos, and I'm mentioning here two clinical trials that are going on currently, and we should know about this in years to come, about what the differences are in the biomarkers between Latinos and non-Latinos. Non-pharmacological options, they're very valid. They reduce symptoms and maintain autonomy, even if they don't have an impact on the process itself, because the brain keeps on degenerating. But maintaining connected socially, doing physical exercise, living healthy, definitely reduces the symptoms of Alzheimer's disease. And finally, a comment that on Alzheimer's disease and related dementias, the participation of Latinos in clinical trials is very, very limited. Here at Sun Valley Research Center, we look forward to getting studies on dementia because we want to have more Latinos participating, because that's the only way we're going to know how well the future treatments will work in our population. So I'm going to close with this image. Just remember, there are medical conditions where patients can have cognitive complaints and not necessarily a cognitive deficit. So treating them properly can prevent them from developing disease like Alzheimer's. So how do we put it all together? Well, keep in mind there are social determinants of health for the Latino older adult in the U.S. There's health literacy issues. Cognitive function is very important, and health disparities are present in these populations. So I'm going to present what I promised. This is an older lady who's been my patient for many years, and this is about 3 months after she came to see me, very sad, very depressed, because her doctor, who gave her a paper copy of an image of her brain CT scan, had told her that she was incurable. And like we say in Spanish, desahuciada, because her condition was irreversible. She became very depressed on that, and this is about 3 months later that we did treatment for her depressive reaction, and oops. Dígame, desahuciada, ¿qué ha pasado? Yo más o menos estoy reviviendo. ¿Qué es lo que has hecho para sentirte mejor? Pues más hago ejercicios y más. ¿Qué es lo que te estamos dando medicina? ¿Estás bajando de peso? ¿Dónde vas a hacer los ejercicios? Allí, después de mi casa, ahí en una señora que va. O yoga, baile, zumba, ¿qué? No, es aeróbico. Oye, de lo que te dijeron, ¿te acuerdas ya hace tiempo que me enseñaste hasta una foto de tu cerebro? ¿Qué has pensado de eso? ¿Cómo le has hecho para mejorar? Algo que me quedé pensando, pues, ¿cómo que pues? Si Dios quiere, pues voy a sobresalir, a ver qué, porque ya me habían desahuciado. ¿Con la pura fe? Con la pura fe, yo creo. A ver, ¿le estuviste rezando? Pues sí. ¿Cómo le dije? No, pues ya me había dicho.
mal era irreversible.
Ajá.
Y luego, así cuando salí le dije, por la lengua salí que chichar.
Y usted será el doctor, pero yo voy a pedirle a Dios. ¿Y qué hiciste? ¿Te podías rezar en tu casa? ¿Fuiste a la iglesia? ¿Leer la Biblia? ¿Qué?
No, pues no puedo leer, pero...
¿Por qué no puedes leer?
Porque no veo.
Ah, entonces, ¿cómo?
Pues, nomás rezando cosas que yo sabía de memoria.
Ah, como el Padre Nuestro. ¿Qué religión haces?
Católica.
Ah, ok. Como rezar el rosario, por ejemplo.
Rezo el rosario. Sí, le pido a Dios.
Nomás con muchas ganas.
Muchas ganas de sobrevivir.
¿Y por qué quieres sobrevivir?
Pues, nomás a ver qué más miro.
Oye, ¿y eso que no miras bien? ¿Qué sería si tuvieras bien buena la vista? ¿Eh? Entonces tú dices, aunque me quede ciega, aunque me quede desahuciada, aunque me... Tú
No
le
quiero
pides a Dios que...
A ver qué más miro.
Muchas gracias. Okay, so if you see the resilience, the lady is diabetic. She's losing her sight, but she wants to continue living to see what else she can see. So keep in mind that becoming forgetful and moody as we age is frequent, but not always normal. I recommend to systematically measure health literacy and cognitive function in your clinics. Develop procedures to address social determinants and improve health literacy in your places of work, promote acculturation, and especially promote positive messages like good health, optimism, social connectedness, independence, and taking charge of one's health. Thank you, and I'm ready for questions.
Thank you, Dr. Ning. So yes, we have a few questions. Let's begin with those. How can mental health care providers better serve the population at the border cities, specifically the navigation through the stigma that exists around mental health in Latinos?
That's a very important question, especially with the environment right now with politics and been developing since our current administration. It's very hard because it takes a move of entire communities and policymakers to make a change. You cannot just start seeing patients who are undocumented now because you may even get in trouble. So this is going to have to be a society's effort. And but on the other hand, those that can make it to your clinics because either to a grant or because they have some kind of benefit or government-sponsored coverage, clinicians must be informed and be sensitive to what they're going through right now. And both documented and undocumented immigrants, because it's been established that for every individual that lives legally in our country, more than 2/3 have what's called now binational families, that some kind of relative will be living in either Mexico or another Latin American country.
Okay, so we have another question. You mentioned assessments that could be used with older adults. Are these accessible online?
Oh yeah, especially the one I mentioned that we use in our office, the mini mental status exam. It's also, you can also find it as the full thing, and it's available in Spanish. And as long as you're using it for your personal practice, there is no charge or cost for using it. Only people who are doing clinical trials have to pay for rights.
Okay, thank you. There's a few more questions. Do you think peer community workers, oh, I lost the question. what did it say? Hold on. Do you think peer community workers, those with lived experience, can work with and help seniors to better care for themselves and take better advantage of care?
Oh, absolutely. And I think we depend a lot on community workers. They may be the key to close the gap between the cultural issues and the lack of services. So yeah, I think that community workers properly trained on issues like the ones we discussed here can be key players to improve and move forward in helping older Latinos.
Okay, thank you. Now we have a comment and a question. First, shout out to fellow alum Go Red Raiders. As a health educator, what program is advised to promote as a starting point to bring awareness?
Well, I think that the main message is what I opened with. Not only because we age, it's okay to lose function. Okay, I think we need to break away from that. Like many times, adult children come with their mother or father saying, well, but, you know, she forgets a lot, but that's normal. It's the age. And I think that's the first message that we need to change. There are some changes that are considered normal and some that are not. And I always like to compare this with the concept of osteoporosis, right? Mm-hmm. The bones get thin as we age and get more fragile, but we pretty much accept now very widely that breaking your bones because with little exercise is not normal anymore. So we've developed this concept called osteoporosis, and everybody accepts that there is too much of bone getting thin that is an illness. And the same thing is with mood and cognitive changes in the elderly.
Okay. You also mentioned that depression during your 30s or 40s may lead to major neurological disorders. Is there any data in terms of persons who received treatment for prior depression versus those who didn't?
Oh, definitely. Definitely. I'm sorry if I gave the impression that there's no difference. No, definitely there's a difference. If you properly treat it, the risk is diminished. Definitely. And,
okay.
And the difference is quite noticeable.
Okay, thank you. We have another question. What do you think of using the Montreal Cognitive Assessment with Hispanic patients?
Yes, it's also being validated in Spanish, it's a matter of which one you prefer. There are some schools that believe that it's better and that it's less biased against education. That requires more of being properly trained for it. Yeah, the MOCA is another very good instrument to use.
Okay, thank you. So that's it for questions from us, from our participants. So again, I would like to thank you, Dr. Ning, for collaborating with us in this webinar, and also to our participants for attending. So as we finish today's webinar, you'll be redirected to complete a brief survey. So thank you, everybody.
Thank you, guys. Bye-bye.
Thank you.
To conclude today's webinar, I would like to thank today's presenter and remind our audience that if you're interested in receiving further training on this topic, you may email us. Please look at our website to learn about future webinars and other services we can provide. As you leave today, you will be directed to complete a brief survey about your experience. Your feedback is very important to us, and we appreciate you taking the time to tell us what you thought of today's webinar.